This is the 22nd edition of Advance Health. Today we've got a wonderful topic to talk to you about, data-driven care, the digital promise. We have three wonderful speakers, Dr. Margaret Foe, Synapse CEO, Michael Shelper, CEO from Anvano, and Dr. Osama El Hassan from Dubai Health Authority. We bring you this event today with our usual partners, so Synapse Medical Services, Dubai Science Park, and Connect Communications. And we also have a special sponsor today in the way of Austrade. And I would like, with that, to welcome Ian Halliday, the Consul General of Dubai for Austrade, to start the event. Ian, if you'd like to come up.
I'd just like to make a few acknowledgements this morning before I just say some opening remarks. Dr. Osama El Hassan, the Health Informatics Specialist, Dubai Health Authority. Margaret Foe, Founder and CEO of Synapse Medical Services. Michael Shepler, CEO of Anvano. And once again, congratulate Synapse, Connect Communications and Advance Health on today's event. I'd also like to acknowledge Moin Anwar. So Moin's the Trade Commissioner for New South Wales Government here today. But it is a real pleasure for Austrade to be partnering this event to bring together the healthcare industry to address challenging and interesting topics, and also, more importantly, finding some solutions. I always, since COVID, it's great to get out and have face-to-face contacts. So it is really good that so many of you have decided to come along today to hear about developments both here and in Australia, because we do think they very much complement each other. In a world where new technologies are disrupting industries in every sector, healthcare providers are looking to adopt relevant technologies to deliver better health care. The benefits are obvious to everybody here today: better and more personalised healthcare for patients and more efficient and accurate services on behalf of providers. Reduced human error, improved clinical outcomes, better care coordination, improved practice efficiencies, and rich longitudinal data over time are really important benefits. The challenges, though, are also very significant. How do we collect and share the data while maintaining patient privacy? How do we enable equitable access to crucial data sets? Pleasingly, the UAE has made great strides in healthcare in recent years. And most, I'm sure, in this room would agree the UAE was amongst the best places in the world during the pandemic. I certainly would testify to that, thanks to the combination of strong leadership, clear policy, and rapid technological development. And I'd have to say Dubai's been humming for probably at least the last 12 to 18 months, and I think it really is a testament to how the government responded to the pandemic. The UAE has invested heavily in the digital health sector, for example, through its Dubai paperless strategy and the digitising of patient files and integration of health systems. Australia has also pushed ahead with our digital health efforts. Our leadership of the Global Digital Health Partnership, a collaboration of 23 countries and the World Health Organization, reflects our commitment to and excellence in digital health. Australia has been ranked one of the best in the developed world for healthcare outcomes and administrative efficiency, according to the Commonwealth Fund Report 2021. We think of ourselves in Australia as having a high-quality healthcare system that delivers services at a much lower cost than our US and European competitors. Austrade, the Australian Trade and Investment Commission, is working closely with a select group of Australian digital health companies as they look for opportunities globally. Some of them during Arab Health earlier this year and Expo 2020, and we continue to work with those businesses across the region. And there's a brochure we've prepared for Expo that you can pick up today to have a look at those companies that we are assisting. And if you do see something of interest, we've got John Kavanagh and Yazan Tai. So John and Yazan, most would know, they're here today to help answer any queries that you may have. The Australian Government Digital Healthcare Strategy has 5 main focus areas. They are investing in the integrated management of chronic illness, developing new digital services to support the health of babies and young children and our older citizens, improving digital services for advanced care planning, improving information sharing in urgent and emergency care, and widening access to telehealth services, particularly in rural and regional Australia. Obviously, many of those focus areas have relevance to the UAE and broader region. I hope you really enjoy today's session. The Australian Government in the Australian healthcare sector really does look forward to continuing to work with and in future development of the relationship with the UAE and the Dubai healthcare sectors. So thanks once again very much for coming along this morning. I hope you enjoy the day. I'd like to now introduce a short video from Mr. Gary Hogan, who's our Deputy Director of Austrade Health Centre of Excellence. So thanks very much everybody and enjoy your day. Thank you.
Good day from Australia, Dr. Marwan and friends at the Dubai Science Park. I'm Gary Hogan and I'm with the Australian Trade and Investment Commission's Centre of Excellence for Health. It's not only a great honour to be with you today, but also a tremendous pleasure. And thank you for the invitation to provide you, in a few minutes, an overview of the health landscape here in Australia and how I think that's providing unprecedented opportunities to partner and learn from our journey. I'd like to tell you that story as a tale of 2 centuries. Throughout the 20th century, Australia built a global best practice universal healthcare system. Better nutrition, public awareness campaigns, compulsory vaccinations, a highly trained workforce, sophisticated diagnostics, and a national medical insurance scheme all produced much healthier Australians as we entered the 21st century. 100 years ago, the average lifespan of an Australian had a 6 in front of it. Today, it has an 8 in front of it. And every decade, that number rises by about 1 year. This is a wonderful achievement, but it's also the source of our biggest health challenge. We are living longer, and that's the problem. If we talk about episodic medical care transacted with a GP or in a hospital, requiring a pill or a needle or a scalpel, Australians are pretty much covered. But our ageing demographic needs a health system that supports the chronic diseases associated with longer life, cellular degeneration, mobility issues and cognitive decline, and that's a very expensive undertaking. In particular, the cost of our aged care system and our social insurance scheme for disability alone are blowing out budgets at an exponential rate. On top of that, the last 2 years of pandemic have placed enormous pressure on our health system. As you may be aware, our states, like your Emirates, have prime carriage of funding and operating the public health systems within their borders. Just last week, our central government struck a shared funding agreement with the states to cover COVID-related expenditure, but only for another 6 months. But it cannot continue indefinitely. Meanwhile, our states simply cannot afford the healthcare cost curve that confronts them. I wonder if this sounds familiar. So in Australia, we're directing more thinking, more research, and more solutions into reducing costs. And it's not just about clinical costs and CapEx at the point of care. There are real dividends to be extracted from the 20th century model of OPEX that our hospitals still run on. And the innovation of Australian companies like Synapse around fintech and other digital solutions is saving money that can be redirected into the core business of healthcare. Health economics is forcing us to imagine what it would be like in this new era of personalised care if the hospital was in the home. Digital technology and the bandwidth to run it have already made it possible to actualise this idea. I'd like to offer you, if I may, one short case study to illustrate the shift in health economic thinking here in Australia. It's a recent pilot project run by Northern Health, one of Australia's 31 primary health networks. It's here in Melbourne, where I'm speaking from. Northern Health found that just 2% of their patients were consuming an astonishing 25% of their budget. These were the so-called frequent flyers. They'd present to the emergency department, they'd get cured, they'd return home, and they'd be back again in less than 30 days for another unscheduled appearance. How could Northern Health reduce the number of visits by that cohort of frequent flyers, how could they be monitored at home, where early detection could trigger bespoke interventions, overseen by a concierge service that could dispatch a nurse, an allied health professional, a nutritionist, a counsellor or a carer in response to the particular needs of the patient? In short, how could a personalised approach for these frequent flyers actually save the hospital and the state government money? To explore this idea further, initially on a small scale, Northern Health used a university-endorsed in-home monitoring system from a company called Haley Assist. And they trialled that equipment with a client population from an in-home aged care provider called BapCare. They then had Victoria University do a health economic study to determine if and how much financial benefit this digital health solution could reap. Now, that peer-reviewed study was released by Victoria University just last month. At least in microcosm, this in-home digital health-driven approach concluded the following. Cost savings of 22% by early intervention with at-risk patients, and 18% annual cost benefit through personally targeted care services, along with several other benefits such as 8% cost savings through the matching of frontline care workers with specific client needs. These are very encouraging results, and I've left a copy of the study with my colleague John Kavanagh if any of you would like to read it in detail. Dubai Science Park colleagues, in summary, Australians are living longer, and that's putting enormous pressure on our health budgets. We, like you, need to drive the healthcare cost curve downwards. Digital health solutions are critical to achieving these savings, and that's putting companies like Synapse and Haley Assist at the forefront, as well as other innovators and pioneers like Northern Health, where they're trialling and introducing technology that will allow the repurposing of resources away from administration to a more clinical focus. We're proving digital health solutions can prolong lives, enhance wellness, and save money. Australia is in a transitional phase from the universal healthcare system of last century to a more fit-for-purpose 21st century model of personalised care. We think that makes Australia a great place to research, to innovate, to partner and to invest for the healthcare needs of this century. We really hope you'll join us on that journey. And thanks for allowing me to join you all today.
Assalamu alaikum everyone. My name is Usam Al-Hassan from Dubai Health Authority. So just to have a brief discussion about advancing healthcare and what's happening in the ecosystem. This is still a strategy of DHA, but just this is a disclaimer, this is an old one. This was before even this announcement of the separation. It was focusing on the main initiative that DHA is talking about. So it's just to give you an idea of the thinking. So we have a lot of objectives talking about promoting lifestyles, leading prevention. And these are almost around 9 initiatives. And eventually we have the 10th one, which is talking about empowering all these goals with digital health. And I see this is old-fashioned because today people are talking about digitally first. You need to put the digital tools and digital technology and digital strategy first before every other initiative. So whatever initiatives that come to your box, then you try to find how to digitize it most way. So because of that, I said this is a very old-fashioned. And this completely now, I can say obsolete. So as you know, like maybe 12 months ago, there was a regulation came from the Dubai government talking about the separation of DHA to two entities, Dubai Academic Health Corporation and the old DHA as only regulator. However, the new law about DHA was very interesting. Although we were talking about the regulatory aspects, there were new aspects that we see for the first time. So for example, preparing and develop smart health policy. So now, regulating digital health is becoming a mandate for DHA. This was not there before. So now we have a full-fledged department called Smart Health and Health Informatics Department, which takes this, the lead in this perspective. Also creating a database of health sector, which includes healthcare service providers, and even doctors, clinicians, and even patients. So this is also a mandate of DHA to keep track of everything happening. And because of that, we see now the NABL system, so we have Shiryan almost a few years ago, but now we have NABL, which will be the registry of all patients in Dubai, seeing all the movements, how they are shopping around the healthcare ecosystem, what kind of drugs they get, what kind of consultation they have. All this information will be in the tip of our leaders' hands to really make evidence-based decisions. And this is a very important point. The third and the last was establish, manage, and operate comprehensive health information system in accordance with international health medical standards in collaboration and cooperation with the new entity, Dubai Health Academy. So here we delve into also regulating technical systems. I'm talking about electronic medical records, I'm talking about telehealth platforms. So we are now getting into this area and already started this journey by the telehealth standards that we implemented on platforms. I'm not talking about hospitals, I'm talking about platforms. So now we are looking to them from the point of cybersecurity, privacy, keeping the data of the patient, being more transparent of the interaction that happens. Maybe we can have even the chance, if there is something wrong, we can go back and get this recording to make sure that things were done in the proper way. Also, there's a very interesting point in the DHA regulation that I think that this will be a game changer for the entire ecosystem. Now this law opens a wide door for DHA to engage in sort of partnerships with other entities, regardless whether they're public or private, to take part of their mandates. So maybe we can talk about inspection. So inspection is the mandate of DHA to inspect private sector to assure quality of service. So we can outsource the service to third parties. So now we have this capability. Before, we couldn't make it. So this will open door for kind of partnerships on improving services. So can give you an example. So if we want to ensure data quality of e-claims. So rather than having our army of inspectors looking into all those entities, so maybe we can use smart solutions, I can call it e-compliance, e-digital compliance, with smart partners who can minimize the cost of this kind of inspection and make it more better and of high quality. So this will be also an opportunity for the private sector. However, although that we have strategy, we have plan, but still we are not alone. There's a lot of partners that we need to work with. We cannot ignore because they also change legal frameworks like NISA or the Cybersecurity Council, for example. If we're talking about population health, data of Dubai sometimes is not enough. I'm talking about public health, for example. So we need to get in touch with counterparts like MOHAP, like DOH. We cannot live without them. And same for every aspect related to digital. So coordinating with all those. So this is one of the core slides that I'm talking about. So what's happening now from the regulatory point of view? Digital health regulatory point of view. So we see novel advances, new trends happening in the market. We need to engage with these new advances. We are talking about AI, usage of AI. We're talking about telehealth. We're talking about things related to IoT. So we need to include all these new advances within our strategy. Business models, so things are changing every day. So we see now new alliances coming into a healthcare ecosystem. We see Pure Health, for example. This is something that we haven't seen before, having an entity that includes insurance and providers. So this is a game changer. We see a lot of acquisitions, mergers happening in the market. We need to take these into consideration. We are moving now from fee for service to value-based care. All these aspects need to be taken. Consumer needs. So now the consumer is looking for more transparency on the pricing, for example. We need, as a regulator, to support that. Patient wants now to protect their data, so we need to take care of that. Patients want more insurance of their safety. And if there's a conflict, they want to have a path. So if they have a conflict with their insurance company, they refuse to cover some service without a sufficient reason. So there should be a path for them to go and fight for their right. Political environment, as we said, we as a federal country, we have different directions going, Abu Dhabi, Mohab, DHA. There will be sometimes some gaps that we need to manage. So which initiative that should go central? Which initiative that can be really done at Dubai level? We need to address these issues. Otherwise, we will have a lot of, can say, unjustified investments. Some of the changes that are happening today, from the legal point of view, we see the ICT law for healthcare. It was a very huge step for UAE. Also, I can say that UAE is the first, maybe MENA country that came up with a healthcare-specific privacy security regulation. This is a very huge step. It really addressed a lot of aspects related to protecting healthcare data, which is sometimes completely different than personal data. So here we identify, for example, sensitive data, which, for example, could be related to mental health, to sexual behavior. These kind of data should be protected in a different way than normally. So this law addresses exactly these needs. We have the data protection law, which came just the end of last year. And also this will add more value to the data protection and of the patient. So we were talking about data in healthcare. This is a huge topic. We have a lot of aspects. Even we're talking about the scope of healthcare data. We've seen a lot of companies coming to us saying, why you should regulate us? We just collect data for PCRs. We tell them PCRs is a health data. Even if you don't have the result, but saying that X person is going to Y medical center to get a PCR, this is a healthcare information that we need to protect. Scheduling, all these data, we're not talking about diagnosis only or the results of labs. It's everything that touch healthcare services. We call it healthcare data. So here we're talking about patient, provider, clinician, practitioner, diagnostics, financials, workflows, medication, devices, public. All these are part of our scope. So it's huge. So I can give example of one of the initiatives that we have is NABID. So NABID simply is a healthcare, it's a platform that collects what we call patient records and unify them in a way. So if I'm a patient who's shopping between Rashid Hospital, Mediclinic, Aster, I want a place where I can find all my data in one place and collect what we call longitudinal records. So this is the dream of any HIE, to collect your data from birth to death across all this. This is the real value. So this will connect hospitals, clinics, diagnostic centers, healthcare centers, whatever. So what are the goals? So we have provide trusted exchange, improve patient care, improve patient safety, improve care coordination, which is one of the key things, operational excellence. These are high-level goals that we want to try to get from NAB. However, if we want to simplify the role of NAB, it's just to get a unified patient. So what I mean by unified patient record means that this is a record which is at least complete, at least from the demographic point of view. So it has my full name, full information, my Emirates ID if I'm a resident. So if there's any data that comes later on, I can really, it will be easy to hook it to this record. So but if there is a record for me, so for example, I got an accident, car accident, I been admitted to the emergency, but nobody knows me. So the nurse will write in the medical record, unknown, unknown. This is a record, yes, but this is not a useful record because it cannot be matched with my to make sure that we really make use of NABID, so we have to make sure that we have the right interoperability across all healthcare systems. So if the data is coming from Mediclinic or from Aster or whatever, these should be in respecting the data standards that we put for NABID. Otherwise, I cannot understand the coding of the lab in Aster if it's different from Mediclinic, if it's different from Rashid Hospital. So they all should abide to things like LOINC, like CBT4, to make sure that we speak the same language. Without interoperability and the enforcement of interoperability, things will not work. So before we leave, I want to do a small exercise to we have a shared view of what is the value of NABID. Okay, so there's a definition in information theory called entropy. So what's the meaning of entropy? I just tried very much to simplify it so we can be on the same page. So putting into consideration information content. So NABID records could be an information content. So that describe how much information in a message, whatever message is actually contained. Then entropy in this context is the expected number of bits of information contained in each message, taking over all possibilities. So that's what it means, that if I give you a message about a patient, how useful is this message to you as a doctor, as a clinician who is treating this patient? What actually will drive our doctors to go from their EMR screen to push NABID button to get information? So for sure they have I can say understanding that when they go there, they will get extra information. So this is what is all NABID about, this extra information that you don't have in your EMR. This is the entry. So how can we calculate this? So I can give you another example of entropy. So suppose that you are expecting a message of an integer number coming to you. So I wanted to get a message to help me to understand what kind of a number is coming. So if a message says the coming number is an even number, so what's the entropy in this message? It's important. Why? Because it eliminates 50% of possibilities. So I will discard all the non-even numbers. So this is what the context that I'm trying to get now. So if we try to apply this into NABID, the HI, what will be the value? So here we see 4 types of information here. So number of records ingested to NABID. So is this give me a value? Is this a value of NABID saying that I have 6 million records today in NABID? Because maybe 50 or 60 or 90% of these are unidentified records, missing information. We cannot use them. There is no interoperability there. It's 0. Even if I have 100 million records. Second, number of unified records. So what's the meaning of that? So these records are complete in terms of information, at least from the demographic point of view. So it has my all data, Emirates ID, full name, age, address. This is a valuable information. If any information comes later on from another hospital, it will be easily hooked to this record. So this is a better one. So we go by a number of linked unified records. So my record, Osama, is on NABID, is unified record. Then I went to another hospital, say Aster. I did some transaction. When they send it to NABID, automatically it will be hooked to my record. So I have now 2 records linked. One from Rashid Hospital, one from us. Another day I will go to maybe Mediclinic. The same will happen. So I will have 2, 3, 4, 5, 6. So if I go back to my doctor in Rashid Hospital and he clicks NABID, he will see what I'm doing. So here we see value. So this number of linked records, the percentage of unified records which are linked is a better entropy of unified. So another layer of entropy say what is the average number of linked records between those unified linked records. So suppose that I will have 2 million unified linked records. What do you mean when I say unified link? That at least there is 2 records connected for me. So this is unified linked record. But I was saying a percentage of average of linkability. So for me, there's 5 records. For Ahmed, it's 10 records. For Saeed is 12 records because he is a high shopper in the market of digital, of healthcare. So the average of these numbers could be, for example, 5 records. So here I will tell my doctors, guys, when you click now, the average of shopping that you can capture is 5. You will get 5 different sources of data other than your EMR. So this is the top entropy value of Nabel. The more that we get from this will be more and more useful. So this is just one piece of evaluation on how Nabel could support the healthcare ecosystem through connectivity. Okay, so I think this is my last slide. I want to invite you all in November 2nd and 3rd. We'll have a very interesting event called Digital Health Workforce Development Conference. It will have more than 7 tracks, or actually 8 tracks. We're talking about normally HIE, we'll talk about digital health innovation, population health innovation, healthcare data privacy, digital health experience forum, and also AI machine learning. So these will be different forums running parallel. So I welcome you all to come to be with us on November.
Thank you so much, Dr. Osama. I concur with every single thing you said, and as a health system lawyer and regulator, I agree that health systems need to be very tightly regulated. It's a real pleasure to be here today. What I thought I would do is I'm going to drill down a little bit into some of the things Dr. Osama was talking about, because I think that for a lot of people, myself included, the concept of health data can be quite confusing. What are we actually talking about? What is going to be in NABID? What is it? Is it words? Is it codes? Is it both? Who is it for? Can we share it? Can we compare it? Can we analyse it? Who has the skills to collect it? And what can it deliver? The answer is, it's both of those things. And what I'm going to do in the next 15 minutes or so is I'm going to talk a little bit about the data journey and what data is, but then I'm going to show you some applications with some of the work that we're doing. So I hope that will illuminate for you what we mean when we talk about codes and why health data has some very unique challenges when we're talking about using it for things like NABID, for population health, for the Australian My Health Record. What are the unique challenges in health data? You'll see there on that slide an image. That is a replica of the Broad Street pump. So I'm just going to take you back in time to 1854, London. There was a cholera outbreak, and a doctor called Dr. John Snow was convinced that cholera was ingested through the mouth. His colleagues did not believe him, but he decided to go on a data journey to prove his hypothesis. What he did, this is how he collected his data, with paper and pencil, or probably parchment and quill in 1854, he mapped the local community, drew the streets, he plotted on the streets, and you can find this map if you Google it, he plotted on the streets, these were his data points, he plotted where everyone had died from cholera. And what he discovered was that their closest source of water, all of them, was the Broad Street pump. So he convinced the local authorities, despite the objections of his colleagues, to disconnect the tap. you'll see there that replica that exists in Soho in London today doesn't have a tap. So he convinced the authorities to remove the tap so no one can get water from the pump, and he solved the cholera outbreak. So just hold that thought, because what I'm going to do is show you how things might have gone for Dr. John Snow if he was dealing with that same problem today. So again, I think it's helpful sometimes to compare that journey that the health sector's on with the banking sector. I'm looking around the room and a lot of you are quite young, so you may not remember these things, but I remember them very, very well. When we were travelling in the 80s and 90s, we had travellers' cheques. That is the way we accessed our money when we travelled, right? So we couldn't access our money anywhere we went. We didn't have these ubiquitous little plastic cards that we have. That didn't exist. It was a words on paper system. And we had to go and you'd take your travellers' cheques and you'd find an American Express office overseas and you'd exchange your travellers' cheques for local currency. That's how we accessed our own money in another country. At the moment, in my opinion, the health sector's really sort of here. We're at a very early stage of our development. Think about it. You can't access your health records anywhere you go. But initiatives like NUBID, like the Australian My Health Record, are pushing us in the right direction. But we are a long way off being actually able to access our health records anywhere, not just in your local country. What if you were overseas? Wouldn't you like to access them there as well? So what happened in the banking sector is little plastic cards came along. And for those of us who are old enough, you might remember that when little plastic cards came along, initially you could only access your money from certain ATM machines. I know some of you are so young, I think you're thinking, plastic cards, machines, what is this thing? But it was true. In Australia, I remember my bank, I could access money from my bank and one other bank in Australia. There were like 5 other banks, but I couldn't go to them because my card didn't work in that machine. So eventually, yes, I know, it's mind-blowing, crazy stuff. Eventually, you could access your money from any machine. And now I do a lot of travelling, well, pre-COVID I did, and I'd go into an ATM machine in some corner of India in a tiny little petrol station somewhere and, you know, stick your card in, you think, can I really get money out of here? And out it pops. And now, even these little plastic cards are disappearing. So I've got a card here with me this week, but I'm really not using it very much. Mostly I'm just tapping my phone everywhere I go. So even the card is disappearing. So for health, I think we're still at the stage where it's like, wouldn't it be great to have a little plastic card where you could access your health? We're so far off. But the bottom bullet point is the one I want to really stress. The way that was achieved in the banking sector over all of those years was internationally standardised information models, messaging systems designed around atoms of data. So let me just hold that thought and I'll just keep moving along. We have international standards in health, we're just not very great at adopting them. So the international standards that we have for health messaging, so it's just a messaging system, is HL7 Fire. I'm not going to go into a lot of detail about what that is because we don't have time. But it's just a messaging system, a bit like the way the ATM machines used to pass information. But even more important than HL7 Fire is Open Air, which is the international standard health information model. If you imagine the ATM example again, you can't say, I'm going to have this data element up here and this one down here, because we don't like to do it the same way as you. That's why I could only get my money out at certain ATM machines. Everyone has to harmonise and say, no, we're having a standardised information model. You put this here, this here, this here, this here, and then you exchange it. So when we have HL Fire and open air, you have what's called interoperability. But that's only part of the story. As Dr. Osama pointed out, that's great for clinicians. That's words. We're exchanging words. So what will happen is, someone will pull up your record and the doctor will be able to see the words that have flowed through the system, and they've got context, they can read it, they know what's happening to you. But words are of no use to anyone other than clinicians. Again, as Dr. Osama said, you would have seen that slide he had with interoperability with all those codes listed on it. So these are the codes we use in health systems around the world. And as you saw on Dr. Osama's slide, it's not one set of codes per country. Every country uses multiple sets of international codes and classifications because they serve different purposes. So we don't have time to go into too much detail on all the different code sets today, but I'm going to focus on one that you saw on Dr. Osama's slides. You might have seen it, and it was ubiquitous on his slides. It was everywhere. In every one of those sections was SNOMED CT. There's a very, very good reason for that, because we're going to talk about detail. We're going to talk about meaning. Now, for those of you who have... Anyone watched The Hobbit? Has anyone watched the Hobbit series? Yeah. Great trilogy of movies in about 2014 that preceded Lord of the Rings. This is a scene from The Hobbit, and in this scene, Bilbo Baggins, who's the little fellow sitting there, the little hobbit, he says to Gandalf, the wizard, obviously wizard-looking there, he says, "Good morning." And Gandalf says, "What do you mean? Do you wish me a good morning, or mean that it is a good morning whether I want it or not? Or that you feel good this morning, or that it is a morning to be good on?" It's a beautiful illustration of health data and the unique challenges in health data. In health data, the same meaning is often expressed with different words. In fact, constantly. There's an example there, and that's from the Australian Digital Health Agency. There's a reference there. When they were doing education on SNOMED CT. So they were explaining there, you can see 4 different clinicians have said the same thing 4 different ways. But it means they all meant malignant tumour of kidney disorder. And that is a SNOMED code in the middle. One of my colleagues who's here today, Cam, I'm going to talk about in a minute, from EBM Analytics, he can share with you his frustrations, chat to him later, because he's got one orthopaedic surgeon in his team that he works with who has 2 patients with identical problems, and he describes everything in their medical records differently. And it's very frustrating for Cam, because what do you mean when you use these words? Think about, ladies and gentlemen, the word cold. C-O-L-D, cold. What does it mean? You can feel cold because someone left the window open and it's snowing outside. You can have a cold, you're sick, flu-y. You can have a cold personality. If you are in a respiratory clinic, the person who wrote that in the record might have meant chronic obstructive lung disease. So these are the unique challenges in health, and that's why SNOMED CT has become the world's standard health terminology, because there's a different SNOMED code for all of those things. It's not one code for cold. There's like 30 codes for one word, cold. What does it mean? Because we need to know what it means, otherwise the data's useless. So let me just give you a couple of examples now. First one is with Cam, EBM Analytics. The problem for Cam was that he's a data scientist. His organisation's a data scientist. They want to analyse the data. You can't use words. We don't want words. We want codes. But once you've got the codes, what are you going to do with it then? So you would have seen Dr. Osama talk about value-based healthcare, which is becoming sort of there's this global push towards value-based care. What does that mean? So what that means is outcomes. How do we measure outcomes? And one of the key metrics is PROMs. We call them PROMs, patient-reported outcome measures. So how are you going to know what to ask your patients if you haven't got coded data? What are you going to ask them? Say, you've had a knee reconstruction. Was the hospital nice? Did you like your doctor? Was the food good? What are you going to ask them? You don't know what questions to ask your patients if you are not coding the data at a very granular level, right? So you might be, every time that patient's going back for a review to the doctor, maybe the doctor's writing in the record restricted range of movement, still only 30 degrees, 6 weeks post-op. You miss all that if you haven't got coded data. And once you start to collect that data, you can say, right, we need to be asking patients about range of movement because that matters to them. The next thing I want to tell you about before I finish is COVID. What can we learn from COVID? So the mass spread of pathogens are often not detected fast enough, and I think we all understand that. If you look at the way this works now I'm introducing another partner company, Michelle over here from Allianz Care Technologies. So it's another organisation we've partnered with. We've plugged our products into each other so that we can deliver the codes back to these wonderful companies and they do magical things with them. So this is what happens now with syndromic surveillance. And there's a lot of information on that slide, so I won't read it to you, but just have a look at the slide. Basically, hospital surveillance is locked in silos, there's no real-time community information sharing, and pathogens are widely spread by the time of the diagnosis. You can see down there, by the time you've got a diagnosis, it's day 10. It's too late. It's too late. It's all over the world by day 10. The other thing is you can't use human coders for this. You can understand that, right? Human coders can only code so many records per day, and SNOMED's not designed to have humans coding it anyway. It's a digital product. So you can't have coders saying, oh, I'll get to that next week. I'm a couple of hundred records behind. I'll get to it next week. It's too late. It has to be real-time coding. So you can see there that what we need to do is do syndromic surveillance and capture things instantly. So ACT has developed algorithms where groups of SNOMED codes equal a fire alarm, if you like, a smoke alarm. It can't say you have COVID, obviously, it cannot diagnose. But with some very clever clinicians over many, many years, they've worked out algorithms that say, well, look, this group of SNOMED codes might be a cholera outbreak. Wouldn't that have been great for Jon Snow? This group of SNOMED codes looks like it's COVID. This group of SNOMED codes might be Ebola. So you start to get codes, and then they send alarms. And what we do is we do the coding. And so let me just show you my last slide, and I'm going to stay on this one for a minute. So this is a slide where this is real data. So this is not, I didn't just pull those words out of a hat. This is a real data dump, because I think to contextualise all the things I've said, it's really helpful to see something real. So see these 3 different data dumps. They came into AirCoder. AirCoder spits out those codes. We give those codes to ACT, to their S4 engine. They put them through their algorithm and they alert or not. Now, a couple of things to look at on this slide. Firstly, it is not a word for code match. That's not what this does. So it's looking at concepts. You can see there's not the same amount of words as codes. It is not like the word cough equals that code. It's much more sophisticated than that. Look at the first data dump, 3rd line down. You'll see the doctor wrote dyspnea. then in brackets, difficulty breathing. Then the next thing he wrote is sob. And someone said to me yesterday, oh, the patient must have been sad. And I said, there's another example of meaning. What does sob mean? Now, if you're not a medical person, and this person wasn't, they thought the patient was crying and was really sad. But if you're a medical person, you know it's shortness of breath. So the doctor wrote the same thing 3 times. Dyspnea, difficulty breathing, sob. We don't want the code 3 times. We don't want it, we don't need it. So you need a very clever machine to work out what was meant by that. Was the patient sad? Was it? So that's an example of the sophistication of this system. In the next data dump, you'll see a W, just a W on its own. This is one of the reasons why natural language processing, which is we use principles of natural language processing in AirCoder, but on its own it's not going to be sufficient in the health sector because W is not a word. So natural language processing will ignore it. So that's not a word. I'm not looking at W. But W is critical. W is critical in that context because it's a concept. It's fever with chills is what the doctor meant. And I've often used the example, NLP, I've seen this happen, ignored DD in a medical record. Just 2 letters, DD, ignored it. It's critical because DD can mean diverticular disease, developmental delay, developmental disability. It's got like 10 different meanings, so you can't ignore it. It's important. And the last one I want to show you, you'll see the word diarrhea is misspelt. And I think it's misspelt. I actually cannot spell the word diarrhea, to be perfectly honest. I don't think anybody can. So you have to be able to handle misspellings because doctors will write what they want to write. And the other thing that sort of underpins digital health is that you have to get out of the way of doctors. What we don't want to do is say to doctors, listen, you've got to change all the words you use. Learn how to spell diarrhea, right? It's over for you. I want you to do... no. We want doctors to do doctoring. That's what we want them to do. You write what you write, the way you write it, spelling errors, symbols, do what you do. We need to use smart technology to get out of their way and support them. So essentially, I think that is the end of my presentation. Just to say that we've come a very, very long way since Dr. John Snow and the Broad Street pump. Thank you very much.
All right, so now I'll take it a little bit to a different area. We heard a lot about healthcare systems. We heard about the data that we have within, the codes and all these wonderful things. I'll now take it a little bit further towards the consumer. I'm sure each and every one of us has a personal story to tell when interacting with a healthcare system about a medical condition where the root cause could have not been identified. Maybe a family member, a friend, a loved one, or you yourself experienced that. I had to embark on such a journey with my wife 4 years ago. For 2 years, we saw a different specialist every single week. The same questions were asked, the same answers were given. The medical records, the paper files piled up, all the examination results piled up. I created even a digital foundation to try to eliminate these silos and connect the data points, to give a brief overview, what was tried, what was ruled out, created a PowerPoint presentation to give literally a snapshot. But nothing helped, we couldn't identify the root cause. You can imagine that my frustration, particularly given that I work in healthcare, was at an unfathomable level. How come that we can 3D print a house in 24 hours? We have self-driving cars, we use exoskeletons, and we are almost like Iron Man. And in a decade we'll go to Mars. But when it comes to healthcare, it sometimes feels like the Stone Age, right? And that is sad, and that is sadly also our reality. What does a healthy lifestyle mean in 20 years' time? Let me be provocative. I think it means we will be constantly sick. We will be constantly having a medical condition. But that doesn't mean that we'll experience any symptoms. With all the wearables, implants, 24/7 monitoring, everything will be identified early on, diagnosed, treated, and we'll never really feel sick. But would that also mean that we will have a shift in how we take care of our health in the future? That we do not really care anymore about living a healthy lifestyle if we are never sick? Well, there's still a little bit of time till we get to that point, but what is clear to me is that today I want to have the right care at the right time, the right advice whenever I need it. But we are facing a hybrid dilemma. On the one side, we have to serve the old generations, at the same time the new ones, but they require very different services. We are also at a transition period from the analog age to the digital. We heard a lovely story earlier on about the plastic cards, which even that is not too far ago. Right? A lot of us are actually hybrids. We went from the analog age and all the way to the digital age. Think about how many of the services that you are using on a daily basis are fully digital and how many of those are truly still analog. Is there maybe a specific industry where there might be a little bit more analog? And at the same time, all of us, we are the ones that have to drive the change of the digital transformation. But what does it mean for us? It means we have to rethink. We have to rethink how we provide care, how we use technology, whom we serve, how we serve, all the way from the old generations to the digital natives. And I would like to classify it into 6 different areas. Innovation is advancing faster than ever before. The way we worked 6 months ago is different than today, and it will be different in 6 months' time. The consumer is rising in power and can't be ignored. We have a multitude of ecosystems that is developing around us way beyond healthcare that is of relevance to us in healthcare. We have to change the culture on how we provide care, how we interact with the patient, with the consumer, and we also have to craft new services. But what we do in healthcare is, before we take the first step, we overthink so much. I see a lot of smiles there. There must be some truth to it. Not sure how true it is, but definitely there's something that we need to do. Technology is advancing at light speed. We all know that. We are experiencing it in our lives. And sometimes we have to go back in time. Think about the announcement from Google a couple of years ago at HIMSS, where they launched a new service. You can now fax your medical information to Google Drive. Well, sadly, that service is needed. You still have tons of medical facilities that are operating entirely on paper. The Internet of Eyes and Ears is omnipresent. Boston Children's launched an ERA skill on Amazon Web Services for parents where the kids were discharged so that they can continuously interact with the care team to provide the best possible aftercare. Department stores are sadly dying. Thank you, Amazon, I would say. Does it mean that the same thing is happening for us in healthcare? Will we not need hospitals in 10, 15 years' time anymore, or maybe only for specialized care? And everything else will be seamlessly integrated into our lives, into our homes, with the wearables, the services are personalized to exactly what we need. Would that be maybe our normal reality? It is clear that innovation needs to advance in healthcare. There are so many advancements coming out on a daily, weekly basis, but how many of those make it into the healthcare arena? And sometimes we have to think about reverse innovation or triple up innovation. Innovations that were created under constraints in parts of the world such as Africa, Latin America, India, and they finally make it into the Western society. They're finally being adopted because these innovations are amazing. But there was a stigma beforehand why they were not adopted. And AI, everybody calls it artificial, I call it automated intelligence, is here to stay. We see the first AI research labs in healthcare, and that is definitely growing because that can exactly yield the insights that we need. Everything in our civilization over the last 100, 200 years is a result of our intellect, of our creativity, our ability to dream, think, build, and solve problems, and that will not change. And there are a lot of challenges that we have in healthcare that need to be solved. Think about the shortage of clinical practitioners. Think about the lack of trust of the patients to the doctors, which is growing. Let me take a little analogy. In 10 years' time, you're on a nice windy mountain road with your self-driving car, and you have this urge, I want to do it like back in the old days. I want to take control. I want to drive myself. So you take the wheel, you'll go up the road. Sadly, an accident happens. What's the first thing that the insurance company will ask you? What do you think? Exactly that. Who is driving, you or the computer? If it were to be you, most likely you'll get full or half liability, right? So we want to increase patient safety. We want to improve the care we provide to the patients. Does it mean in the not too distant future, if AI was not consulted prior to treatment, it would be considered malpractice? Could be. Technology is here to augment us. And we really have to create the best possible decisions for our patients. But let machines do what they're good at. Anything that is on the right side, administrative, pattern recognition, predictable, something where you really need to create insights out of data to provide it to us, to let us do what we are good at, to build up, maintain relationships, to apply our creativity to the problem at hand, to utilize our contextual information, or maybe to provide empathy, which most likely machines will still take some time till they can do something about that. 90% of the jobs in 2030 have not yet been invented, and that is okay. If I would have told you 10 years ago, today you would be a millennial generation expert, a YouTube contributor, a Zumba instructor, you would have thought that's really bad Chinese from a German, don't you? Would it be too far-fetched if we were actually have, in the not too distant future, a surgeon wearing a VR headgear, navigating a nanobot through the human body, performing the surgery, aided by artificial intelligence to provide the best possible outcomes? I don't think it would be too far-fetched or too futuristic. But what is clear for us today is we have to advance ourselves and we have to advance our staff. Because the e-consumer, and I intentionally call it the consumer to really get away from the sick care, the patient setting, the e-consumer requires different services. But what is the e-consumer standing for? What is this E? Could it be electronic, empowered, equipped? Would it be the expert or the engaged consumer? They utilize various different data sources. They're hyper-connected. They require a personalized service in everything they get because they want to take a very active role in their recovery, in their care journey. But we are the ones that are sometimes resistant to change. An average patient interacts 5 to 6 times a year for 20 minutes with the healthcare system. These are the data points we collect. We heard that early on from Dr. Osama, from Margaret. These are the data points we want to take informed decisions on. Sadly, that leaves another 364 days and 23 hours where each of us is taking decisions that impact our lifestyle. We have choices that impact our health. We leave digital breadcrumbs with the wonderful smartphones, with the wearables, with everything that we use day in, day out. But these data points are not utilized, but they would be so powerful to create a positive impact into our lives. We can't do that. Well, this is exactly where, for example, automated intelligence comes in, to go through these data points, connect them so that we have the right insights, that we can actually do something with that. But is that core of the services that we do? Most likely it isn't. And it means that we have to find the right partners that complement our services so that we get closer to the consumer. And sometimes we have to think about very uncommon partners that actually give us the insights of these digital breadcrumbs so that we can do the right decision, take it, do the right service. Think about Lyft and Uber that partnered up in the US with providers because they identified that the biggest problem of no-shows, which is typically around 30%, huge operational and revenue impact for the providers. The root cause is lack of transportation options, typically for the elderly, in remote areas that sometimes are from poorer populations and have a high degree of medical chronic conditions. So by providing a service to integrate exactly that and pick up the patients to get them to their appointment, they were able to reduce the number of no-shows, depending on the area, by 18 to 27% in one go. But that means we have to change our culture, right? We have to change the way we are providing care. We are interacting with the patient, with the consumer. Data is now available not only to the caregiver, but to the consumer and the patient alike. That means maybe democratization of care as we know it. Think about the bad consumer experience you had in the last 12 months. How did it make you feel? And I can promise you had plenty of that in Dubai. And my heart rate, oh my God, let's don't even talk about that. But now think about the really good customer experience that you had. Did you maybe feel comfortable? Did you feel valued? Did you feel that your problem was taken serious and you got the help that you needed? And maybe it even resulted in you being a repeat customer. We get advice from so many various data sources in the healthcare system, but when do we actually ever obtain advice from the patients, from the consumers? How many of you have patients or consumers in your advisory boards? We need to recognize the value of technology and dare to use it, because then we can actually lift up this relationship to a true partnership. We have to encourage the patients to tell us what they learned, because guess what? They will consult Dr. Google anyway. And if they do that, you'll have the medical school syndrome. Most likely I'm in menopause right now if I ask Dr. Google. So I cannot navigate it effectively, but the clinical practitioners can. We have to educate the patients how to navigate so that they can be well prepared for the next visit and actually can be an active part in the entire care provision. By doing that, a lot of time can be saved that can be dedicated to more complex cases that really need it. And at the same time, we also have the possibility of tackling the burnout problem for the physicians, where over 50% are actually having some sign of burnout, by applying technology on a daily basis in the routine things so that we really create an impact. AI needs to be embraced and is there to stay. But what is it really that our patients, that our consumers need? They need empathy, time, and attention. But particularly time is very scarce for us in healthcare. But bridging that with technology means we can free up time. Our services that we need to create have to be accessible 24/7. Can we do that? We can't. And the empowered consumer most likely would rely on some technology services, health apps, AI for silly medical conditions anyway, because whenever he or she wants to have the service, he or she can. It has to be personalized. None of us likes plain vanilla when it comes to something as close to us as our health. It has to be preventative, and it also needs to augment whatever the patient, the consumer is doing. Let me get back to the story from the beginning. I would have appreciated very much a service at my fingertips that is seamlessly integrated into my life, into the life of my wife. To connect all the various breadcrumbs that we create within the healthcare system, but also outside the healthcare system. To generate the insights to enable us to navigate effectively the healthcare system and get to some person to help us identify the root cause, outline treatment to recovery. This doesn't need to remain science fiction. If you need some inspiration, have a look at the book that I co-authored called Hybrid Healthcare. But ultimately, the power is with us. We have the power to ensure a structured and clinically curated data flow along the entire patient journey. We have the power to change the culture in how we provide care. We have the power to focus on the consumer and lift up this relationship to a true partnership so that all of us can live a healthier tomorrow. Thank you.
My name's John Kavanagh, as Tom said, and I'm the Deputy Consul General. It's my pleasure to facilitate the panel. For the first question, I might go straight to our regulator, Osama. If I can ask, I'm going to put you on the spot and say, look, we're all looking for certainty around data residency legislation in the UAE. When might we have some real clarity on data residency laws here in the UAE, and what have been the big challenges about getting this over the line? I know it's complex.
This is a very good question. So the challenge that we have today, that we have two powers that are controlling this. So we have the ICT law for healthcare, which is also, yes, it was under MOHA, but still DOH and DHA have a very good kind of flexibility to execute their own policies under it. So it's kind of now implemented in a federated way. So, and unfortunately, we are going in different speeds. So maybe DHA is going a little bit faster, especially with the telehealth regulations, and we are trying to tap into all digital health platforms. I feel that even the MOHAB and DOH will follow very soon. The other layer of difficulty that we have now, after the data protection law was launched in, I think, December 2021. So now we have another player coming into the space, which is the Cybersecurity Council. Fortunately, before launching the law, we managed to include our ICT law as part of the recognized policies within the data protection. So that means simply that anything related to healthcare data, it will be referred to the ICT law, not to the data protection. Where in the ICT law, we have more details, more granularity with regard to data classification, because we have a separate concept of data classification than the general health data. Because here in healthcare data, we are talking about primary use, secondary use. We are talking about sensitive data, non-sensitive. These concepts are not in the generic data protection. So this is the good news. However, we still need the Cybersecurity Council to come up with a clear direction on exemptions, especially on the data residency part. We are still waiting for this piece so we can move faster. So that's it.
Thank you, Osama. I think sometimes in the UAE we get a bit spoiled and we expect legislation to move very quickly. My home country in Australia, and I imagine other jurisdictions present here, legislation is incredibly complex. Multiple stakeholders takes years. So thank you for your answer. I appreciate it. The next question I'm going to direct at you, Margaret. Hi, thanks for joining us. That was a great presentation. I really enjoyed it. Who's doing that really well? Now, you've travelled a lot. I know you've been in Australia for most of the pandemic, but who is doing the coding and the data and trying to get us all working off the same ATMs? Who's at the forefront of those efforts? Who's doing it really well?
Thank you, John. Good question. Look, in the course of my PhD research, I did a lot of comparing of health systems around the world, because part of the work that I had to do was to solve problems. Every health system has problems. No health system is perfect. You can't pick up a health system and plop it in another country and think that's going to work. It doesn't. So what I did was a bit of a global review of what's going on out there in the world and how are other countries solving some of these problems. One of the countries that I must say was a bit of a standout for me in terms of digital health and digital transformation would have to be Israel. Without question. Just in terms of how far they've come in innovation, supporting startups. But we all do that. I found that a lot of countries do that sort of work, but are not very good at keeping it cohesive. Because what can happen is, code sets and things can become divergent. People go off on their own tangents. So that's my impression, that Israel is doing amazing things in the area of digital health. I think in a health system like Australia's, we have a mature health system. It's 40 years old. So what that means, and like the NHS is another very, very mature health system. What you get in mature health systems is the regulatory frameworks become a little bit chaotic over time, and that's just how it goes. Lots of changes of government and everybody's trying to do new things. And so it's harder to do some of the innovation because you've actually got to do the work under the innovation first and get the regulation into a cohesive whole. And one of the things I'm very admiring of in the work that Dr. Osama is doing and what's happening in this region is that the regulator seems to be at the moment one step ahead. Whereas the law, you know, can be a really slow beast. It always plays catch up. But my impression here is that the regulator's one step ahead. So I think that's very promising for digital health in this region.
Yeah, thanks, Margaret. I think that's one of the great... It's not an unusual story here in the UAE for the government to actually be leading the way. Takes a little bit of getting used to when you first arrive in the UAE, and it's a full credit to the administrators. Michael, a question for you, if I can. I got a bit excited during your presentation. You know, you're thinking about the future of precision medicine and the idea of doctors driving nanobots through my body at 100 miles an hour is invigorating. In that book that you're writing, what was surprising? I think if we could all guess about the genesis of the book, you know, and what might have inspired you is the story you told about with your spouse. Can you talk a little bit about what made you sit down and put pen on paper and put those thoughts down, and what was surprising about doing that? What did you learn?
I think different things. In the beginning, particularly in the last, decade where I spent a lot of time on healthcare technology, I interacted with a lot of doctors and always got the same question. Will I get replaced by AI? My answer was always the same. No, you will not get replaced by AI, but you will get replaced. And that was the deer in headlight moment. Deer in headlight moment, and what you just said, I will not get replaced. Whom will I get replaced by? And a doctor will get replaced by a doctor that dares to use technology to advance his or her services and skills to provide better outcomes. And what was clear for me that in the future of healthcare, we will not eliminate the human in the care provision. But as in the last three industrial revolutions, the way the role is being portrayed needs to evolve. So for me, it was imperative that I utilize the skills that I have, but also complement it with other territories, from the fintech industry with respect to blockchain, from really getting into the research field, chronic condition management. That's why we brought together a set of really brilliant people in the healthcare and life sciences arena around the world to write something that touches across the entire value chain, from the patient is actually not a patient yet, but a consumer at home, which I think all of us can relate to, and we want to ultimately do population health management, proactive health management, but then through the entire care journey with potentially crazy, substantial interventions, which have a different flavor to how you will interact with the healthcare system in the future. And that is why we basically brought this group together to bring this collective wisdom to the world, because we believe we are in dire need of advancing healthcare further, and maybe there are some thoughts which will help people to implement new services to maybe push the boundary a little bit further.
Yeah, thanks, Michael. I mean, in a way, it sounds incredibly exciting as a consumer of medical services, personalised in the home, away from institutions and, you know, sort of these reservoirs of knowledge that have been incredibly hard to access. I would be terrified if I was a mid to late career medical professional. I think they're going to need a whole lot of new skills. It's going to require a lot of retraining. Thank you for joining us today. We had 3 really high quality presentations, and so thank you, Margaret, Osama and Michael, for giving your time this morning, and thank you to the audience too for giving your time.